Today's module is on ACL tear, or anterior cruciate ligament tear. It's a very severe injury of the knee. It's not very common in my clinical practice, but I'm including a module for this because it's important to diagnose and identify early. And I've been surprised when I've had patients with ACL tears that they have gone undiagnosed. The key part of the diagnosis is really the history. This is not something that occurs if someone's just casually walking downstairs, or if they're increasing their cycling from 20 to 40 miles in a day. It really typically involves abrupt, strong forces, sometimes a lateral impact on a planted knee, and it often presents with acute knee swelling and real problems with knee stability. I would say if it's a complete ACL tear, the important thing for a patient is to get adequate treatment, typically from an orthopedic surgeon who specializes in knee injuries. But I'm including this in the module because I think it's important, for example, with primary care providers, to make an accurate diagnosis early and to initiate correct treatment. So for ACL tears, typically this is a traumatic injury. It's not the type of thing that happens because someone cycled too hard on a Saturday and now on Monday they're unhappy. It's typically competitive sports, a soccer injury, a skiing injury. And typically what happens is there's a sudden pulling forward of the tibia with respect to the femur, and the ACL, which is inside the knee joint, is overly stretched and torn. That can also happen with a twisting injury. You might see it, for example, the football player, their leg is planted on the ground and they get this lateral force and it ruptures the ACL. Sometimes we talk of an unhappy triad where the ACL deep in the knee will rupture, but also the MCL, the medial collateral ligament, will be torn, and the medial meniscus, which is here. Although newer literature is saying apparently the lateral meniscus could be injured in this area as well. So but they talk about an unhappy triad of the ACL, the medial meniscus, and the medial collateral ligament, but sometimes that part of that triad is actually the lateral meniscus. On history, what you'll also learn is patients often have a lot of acute swelling, probably from hemarthrosis, from blood in the joint. And subsequently, when the swelling dies down, they'll still feel this sense of instability. If they turn quickly, they can even fall because they don't have that stability that the ACL offers, keeping the femur in close contact with the tibia. Older patients who may not return to very heavy physical activities or competitive sports might live without an ACL, so-called ACL deficient knee, but younger patients usually want to repair surgically. This is not really a core part of my practice. I just feel it's important for me to make the diagnosis to get them to the right person. It does turn out that patients who have ACL deficient knees over a lifetime will be more likely to get secondary meniscal tears later in time, as well as knee arthritis. So again, if you have a pretty active lifestyle and you want to continue with that, you probably need to get your ACL repaired. I think that's basically what I would say in terms of history. In terms of physical exam, again, you often would see a fair amount of swelling acutely. There's a lot of talk in the orthopedic literature about Lachman's test. I'm not really that strong and burly to do that. So I usually still just use a anterior drawer test, where you're looking for the tibia coming forward excessively with respect to the femur. Again, because you don't have this constraining ligament inside the knee holding it closer, you don't have this constraining ligament inside the knee holding the femur in closer proximity to the tibia. You could also test for medial and lateral instability. For example, if you think the MCL has been affected, and that's so-called valgus testing, which will stress the MCL, and varus testing, which stresses the LCL. The LCL is interesting. It's the most palpable of the knee ligaments, in my opinion, but it's also the least injured. You can often just palpate it off the side of the femoral head. I can feel it right here in Jennifer's case. Unfortunately, it's rarely injured, so even though you can palpate it, it doesn't tend to be very involved with most injuries. And then again, the other things we've talked about with medial meniscal tear, et cetera, apply for ACL tears as well, in terms of whether there can be more than one thing going on. Again, mostly not in my wheelhouse, but at least I get the patient to a good orthopedic surgeon who can help them.